that's joining us. We have a really great program tonight. I'd like to start off just by talking really briefly about what the Right Care Alliance is. If you haven't attended any of these, or if you're not familiar with us, the Right Care Alliance is a grassroots coalition. It's comprised of clinicians, patients, community members, and we organize to make healthcare institutions accountable to their communities, and most importantly, to put their patients before profits. And that should be at the heart of all healthcare. I'm really honored to introduce a fantastic panel that we have tonight that's going to be speaking. To start off, we have Stanley Richardson. He's a Gainesville Poet Laureate. And in addition to being a renowned poet, he's an actor, a playwright, and a social political commentator, as well as a lecturer. So welcome. We also have Father Alan Bauer, who is the UF Shands chaplain. He is outreach preacher for the Cross Catholic Outreach and was previously a command chaplain for the United States Marine Corps. And he served 28-year in the Navy. We also have Reverend Sharon Austin. She serves in Connection Ministries for the United Methodist Florida Conference. In 1986, she participated in the 54-mile walk from Selma, Alabama to Montgomery, Alabama with Congressman John Lewis. We also have with us Dr. Grant Harrell, who is an assistant professor of medicine at the Department of Family Medicine at the University of Florida and director of the Mobile Outreach Clinic. We have Dr. Peter Carrick, professor and chief of family medicine, who has been instrumental in increasing UF Health's presence on the east side of Gainesville. He's dedicated his career to improving the quality of patient care. And finally, we have, proud to announce Dr. Fred Southwick, who's a professor of medicine and the chapter leader of the Gainesville Right Care Alliance. And so I'd like to turn it over to Mr. Stanley Richardson.
Thank you. Thanks again for inviting me to this forum. I was talking to Dr. Fred, and I explained to him he apparently is a lover of poetry. His sister is a creative writer and a poet, so he asked me to share some poetry this evening to kick this off. So I was talking earlier that last month I was contacted by the Florida League of Women Voters to assist them in their statewide media effort to expand, bring awareness to the need to expand Medicaid. So they asked me to write a poem about Medicaid expansion. So I got being the Alachua County Poet Laureate, I got the okay from the Alachua County administrators that I could, go ahead and do that, and they would back that. So I wrote something, and I'm gonna share it here today. So you'll be my test audience. So you can let me know if you dig this or not. So Florida is one of 13 states yet to expand Medicaid. Over 1 million low-income uninsured adults would receive health insurance if through Medicaid expansion. So just a little bit of data. So here we go. Ba-da-doo bop, bop bop, ba-da-doo ah. Ba-da-doo bop, bop bop, ba-da-doo da. Ba-da-doo dop, bop bop, ba-da-doo da. Make me want to holler, throw up both my hands. Make me want to holler, throw up both my hands. Mother, mother, there are too many of you crying. Brother, 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 there are far too many of you dying. You know we got to find a way. My country, 'tis of thee, sweet land of liberty. Of thee I was thinking If the poet sings, will it make the suffering more real? If I composed a concerto instead of a poem, arranged an orchestra, put the pain to music, could you then feel the rhythm scream? If I resurrected not the Son of Man, but Marvin Gaye, Bo Diddley, Tom Petty, we sat in a holy circle singing Willie Green's blues. My baby ain't got no shoes or health care. Would you then dare to care? But the poet doesn't sing the poet poems as did the prophets to the kings. When COVID came, a plague marching its a cappella death song laid bare our ugly underbelly, rolled us over onto our exceptional systemic side, showed the world how we live, how we die, how we fall through huge gaping holes that you consider cracks. Show the world how we live, how we die, disproportionate, essential, less privileged, workers, indigenous, black and brown, the other side of town, redlined over eons, stacked like tuna in a tin, unable to escape death's breath. Its 6 feet tentacles when COVID came knocking at our toil and scuffle. This ain't living. Ghost of the uninsured, gone too soon to woe and dust, haunt us from the other side of soup lines, just below the poverty index. Give us health care. Give us health care. Expand Medicaid. Give us health care if you care. If you care. If you care. To have no concept of terror. To have no concept of terror, the sickening unknown, what holds tomorrow, today made all too real, the cost of your child's next meal weighed against the price of a pill. To have to choose is horror. Something heavy, thick and wicked this way wails in the halls of injustice, just outside the lawmaker's chamber. You severed your soul to spite your neighbor's getting. Righteousness wails in disbelief. Citizens poor, sick, and dying petition powers for relief. Brazen neglect, a life of grief. This ain't living. Give us health care. Give us health care. Expand Medicaid. Render us aid. Give us health care if you care. If you care to do the human thing, the good thing, the right thing. Empathy, decency is all that is required. Without politics, without political party, partisan antics, without debate or hate, without despise, peering through racist eyes, though I fear therein lies the rub. Thank you.
I'm very grateful for the opportunity to just share a word regarding awareness of the healthcare disparities that have been highlighted during COVID, but have been in existence long before COVID. There have been a number of studies that address the inequities in healthcare. Among them, my interests have really increased along the lines of Black women and infant mortality. And so there are statistics which have pointed out the fact that Black mothers are 243 times more likely to die of complications of a pregnancy than their white counterparts, that Black people were 3.6 times as likely as white people to have their legs and feet amputated as a result of diabetes, even when other factors were equal, and that cesarean sections were 40% more likely among Black women compared with white women. Now, this information was actually a part of a New York Times article written by Linda Villarosa, and she pulls her statistics from an article entitled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. It was published by the National Academy of Sciences, and now this study is years old. And so the conversations in which we find ourselves now with COVID just really highlight issues that we have not addressed or have addressed very poorly. And it came to my attention to speak to it as a part of an article that I was asked to write and posted on the conference website, and then picked up by the United Methodist News in May as we approached Mother's Day. My husband and I are the parents of 4 young adult children, and I was celebrating my first Mother's Day as a grandmother. And I recall that our daughter-in-law had to undergo an emergency C-section. And because I had already heard about these statistics, along with all of the reasons family members would be concerned in a situation such as that, it just called to mind and brought to the forefront, now with the onset of COVID and the loss of life and the continuation of highlighting the fact that people who are considered essential workers are also often those who are people of color, who are African American, and whose lives represent a chronic underservice when it comes to healthcare. Of particular note to me in the article was the fact that people of color are treated differently when they enter the healthcare system. And that's what Villarosa specifically states. And that because of that, everything that follows in terms of lack of attention to complaints and concerns about pain, being given every opportunity for rehabilitation, physicians who sometimes speak to Black people and speak to them in a way that assumes that their healthcare challenges or probable outcomes are directly their fault, which does not take into account what it means to be poor, uneducated, and instead comes out sounding more like non-compliant and unworthy of our best efforts. I read studies where there is even a concern that when Black people, especially women, complain of pain, that somehow that is disregarded, as if to say, it's really not that bad, you can take it. And so I think we are at a pivotal moment in this country where we have an opportunity to respond to realities that are probably widely known in healthcare circles, but in the greater sociological conversation. And I think I shared, Dr. Southwick, when we last spoke, that the process of what is called weathering, that is the effects of what it means to live with the trauma of racism in the United States, actually wears on the bodies of Black women, and as a result, sort of depicts them as being 7 years older in terms of their bodies, the age of their bodies, than their white sisters, even at the same age. So, you know, if you could imagine being a 30-year-old woman and making a decision to begin a family and finding out that your body is really more like closer to 40 because of the constant trauma of racism and the hormones that are released by the brain and having to deal with oppressive structures and systems and the toll it takes on the body. I would mention one organization, a nonprofit entitled formoms.com, and maybe I can put that in the chat. It was begun following the tragic loss of a mom while in the hospital, a healthy African-American mother giving birth to her second child, and that family's efforts to help pass the Maternal Death Act in December of 2018, which now helps the CDC and other organizations to do the research and collect the data that will help provide state and local surveillance of maternal mortality. These are just a few of the healthcare concerns. Of course, the list and the conversation is much longer. I will just say in closing that as a chaplain at Grady Hospital in Atlanta, and as a chaplain at Jackson Memorial Hospital in Miami, both large, well-known hospitals affiliated with top-notch medical schools, you have an opportunity to see a lot, and you can begin to sense the gaps in the conversation when patients are given a diagnosis and then given information regarding their best outcome in a prognosis, and realizing that all of the sociological factors that would play into helping that prognosis be realized at an optimum level are precisely what is missing from the conversation. So we have a lot of work to do, and I thank you for allowing me to share for a few minutes this evening.
Thank you very much, Reverend Austin. We really appreciate your being here with us tonight. Next, I'd like to introduce Dr. Grant Harrell from the University of Florida.
Thank you. And Reverend Austin, that's actually a very nice segue into some of the specific things I wanted to talk about health inequities. And there's three main things that I'd really kind of like to get across, three main points. And the first point is exactly what you were starting to mention, is that social factors, which traditionally are not thought of as non-medical issues, which are thought of as non-medical issues, they're not really traditionally thought of as medical issues, are really probably some of the most important, if not the most important contributor to health in general, and specifically to why we have health inequities. The second, and I'll go into that a little bit more in a bit, second thing I want to get across is that increasing access to care, and I'll specifically talk about what I mean by access to care, but increasing access to care is not sufficient for reducing health inequities. It's a part of it, but it's not sufficient. And then the final thing I want to briefly touch on is that looking at important considerations like preventative care and wellness, such as and access to information, access to physical spaces, access to nutrition that promote prevention and wellness, that's really critical for improving community health and reducing disparities. It's not just access to hospitals and clinics. It's these other wellness, preventative approaches in the community that are super important. So that first point that I mentioned, the social factors. So the Robert Wood Johnson Foundation has done a fair amount of research on this, and they've really combed through a lot of county health data from across the country. And what they found in their research is that, quote unquote, access to care and quality of clinical care, what they sort of combined as clinical care factors, explained about 20% of the variance for health outcomes such as length of life and quality of life, which is what they were defining as health outcomes. And so it leads you to ask, well, if the clinical care is just 20%, what's the other 80%? And the way that 80% was broken down is about 40% was socioeconomic factors, which you were starting to mention, Reverend Austin. When we talk about socioeconomic factors, these of course are employment, education, income, many different factors involved there. And that explained about 40% of the variance in health outcomes. Another 30% was explained by what we would sort of lump into health and lifestyle behaviors. These are things like tobacco use, exercise, diet, sexual behaviors. And so that was about 30%. And then the final 10% of that made up that other 80% of sort of non-clinical factors were what they call physical environment. And that's, housing, transit, environmental pollution. And so really we typically think of, healthcare in terms of that quote unquote clinical care dimension, which is really just that kind of 20% role that they identified. And I'll give you an example. So I give a lecture to third-year medical students each year about the social determinants of health, which is a term that we use in medicine to kind of describe the impact of these social factors. And it's one of my, I give several different examples, but one of the ones that I think is the most powerful is one of my patients who was a diabetic and was previously really well controlled, but suddenly her diabetic control was really going down fast. Her A1C was steadily rising. That's a marker of how well controlled someone's diabetes is. And I sort of go through this example about how we as a clinic and as providers, we did all of the right traditional clinical care things with recommending the right things to do in terms of diet and medications. We prescribed the right medications. We titrated up the doses properly. And all the while we were doing that, her A1C kept getting worse and worse and worse. And so what was it that finally turned out to be the most important factor? Well, she had switched from being on day shift to night shift. And so when we discovered that she switched from day shift to night shift, I begged and pleaded with her, said, I'll write your employer notes. I'll get on with HR. I'll tell you, you have to switch. You have to switch from day shift to night shift because this is what's got your glucose out of control. Sure enough, she was able to do that. She was able to get switched back to day shift. The next visit where we were able to check her A1C, it had basically gone from completely wildly out of control on high doses of insulin to absolutely excellent control. And we started reducing her insulin doses just from that one shift, which was a social factor. It wasn't a clinical care factor. And so I thought, that's a good example of illustrating what the Robert Wood Johnson Foundation is meaning when they say this 80% of other things is what's really important for health outcomes. So in talking about access to care, as I mentioned, I'm defining access to care as having insurance and then sort of access to healthcare facilities, sort of physical facilities. And that's kind of what our national conversation has kind of been around, of how we need to change healthcare and how we need to improve access. We're talking about things like Medicaid expansion, Medicare for all, making sure that people can get access to those health facilities and the doctors and the nurses and whoever are taking care of them. And I'm not going to argue that that's not important and that we shouldn't be talking about that. We certainly should. But if we solve that problem, we're not going to magically have healthcare disparities solved. It's going to be one piece of the bigger puzzle. And I'll give you an example of why that's the case. So on Thursdays, I do with medical students, we do a street medicine outreach to homeless individuals, and so we're providing medical care to people on the street. And a number of people that we come across have Medicaid, and in fact, they're not even necessarily unable to get to a clinic or the hospital right now. RTS is free. so folks can use the bus. And so on the surface, it seems like, okay, this is a person, they have insurance, in theory, they have transportation. And so, so what's happening? Why doesn't this person have their medicine? Why aren't they, why is their blood pressure so high? Why are things so out of control? Well, a perfect example is a gentleman we saw a couple weeks ago, and when we were talking to him about his blood pressure and some of his other medications, and his blood pressure was super high, and he hadn't been able to get his medications. And I said, okay, well, you've got Medicaid, and did you ever have a primary care doctor? Well, yeah, I had a doctor, and I was seeing him over at this clinic. I won't name the clinic. And I said, okay, well, what happened? Well, I was discharged from the clinic for no-shows. And I said, okay, well, how did that happen? He said, well, because of COVID, we were having to do telemedicine only. We weren't allowed to come to the clinic. And he actually had a cell phone with capabilities of getting on Zoom. But he said, yeah, I tried to do the telemedicine visit, but I couldn't figure out how to do it on my phone. I couldn't get Zoom, and I couldn't get it to work on my phone. And so I missed 2 visits because I couldn't get on, and then I was discharged from clinic. So now this is a person with Medicaid who has no effective access to healthcare, right? And it's because he didn't have the education to understand how to get Zoom downloaded on the phone, use it, wasn't necessarily technologically savvy enough, which again goes back to those sort of social factors, the education, the awareness of how to utilize various technologies amidst all of the other social complications that come with being a homeless individual. So again, if we just give everybody Medicaid or have, build more clinics or whatever, that will have some impact, but it's not going to magically fix the problem. There's actually some interesting studies on states that expanded Medicaid and looking at rates of cancer screenings, important cancer screenings, and did that make a difference in the amount of people that were getting cancer screenings once they expanded Medicaid? And it turned out it only moved the needle by a couple percentage points, very, very small amount. And so again, I say that to emphasize that we've got to keep our eye on the ball, even beyond just the conversation around expanding insurance coverage. We've got to think about how do we also improve these social factors? How do we advocate for more jobs, for higher incomes, for better housing, for less pollution? All of these kind of really important social factors. And finally, just the prevention and wellness thing. I just want to mention that because it's really the most cost-effective way for us to improve community health at large, and then in turn help reduce health disparities. We need to create healthy spaces for people to be able to carry out the instructions that we give them about how to live healthy. We need to provide access to healthy foods. We need to create ways of improving community health education, not by just requiring you to come into my clinic, into my exam room so that I can sit down and talk with you, but how can I deliver community education to you where you live, where you're comfortable being? Can I have community health workers that I bring from the community, people that and that we help build up their health education skills, and so then they can be the ones delivering health education. Can they come to your home? Can they come to your church? Can we be leading healthy activities in the community, not just in clinics or in the physical therapy building or wherever, but can we have spaces where we're doing yoga, where we're doing community gardening, where we're teaching people how to cook, how to cook in healthy and affordable ways? These are all the kinds of things that we can do outside of the clinic. We don't need clinics and hospitals to necessarily do these things. And these are the things that encourage that 30% of health and lifestyle that we know leads to these health outcomes. That's how we can start to attack those things and improve along those dimensions without necessarily having to invest millions and millions of dollars on, buildings and fancy equipment. This is communication. This is just talking about ways to live healthier. So I'm sure I've gone over 5 minutes. I apologize, Fred, and I'll turn it over to the next speaker.
Thank you, Dr. Harrell. That was great examples of tying our medical health along with our social factors. Our next speaker is Dr. Peter Carrick. He's the Chief of Family Medicine and he's going to speak to us a little bit as well tonight. He's dedicated his career to improving the quality of patient healthcare as well.
Thanks, and I'll probably just try to expand a little bit of what Dr. Harrell said, but also maybe give another perspective and maybe have some time to listen to folks. So as Dr. Harrell noted, yeah, a lot of the care we provide can only go so far, and the social determinants of health are really significant and need to be addressed. As a family physician, you would imagine I'm a big proponent of primary care. And primary care is kind of a low-tech, high-touch way of delivering really needed care to individuals. And if you look at countries around the world that have a really established, well-structured, organized primary care, they really don't experience the health disparities that we experience in the United States. So part of, I think, to add what Grant said was, expanding our primary care services throughout the community can only help. It can be a vital resource for everybody in the Gainesville community and help reduce some of the healthcare disparities, also help people live a better life, a more healthy life. We do have a lot of research, and we're trying to do a lot of research and quality improvement within our department and utilizing our practices all across Gainesville. And I really think it is imperative for us, especially in primary care, to really do the research on these healthcare disparities to better understand why quality of care is not being equally provided across spectrum. Because we really need to look at individual practices and individual patients and make sure they're absolutely getting the best care possible for what they need to be done. On the flip side, and this is kind of my ask, and I'll limit it to this last thing, is really we're here, and really as primary care providers, here to listen and really want to understand what the community, what the individuals in the community want from us in terms of their health care and what do they think are lacking. I know we've worked well with like the Alachua County Christian Pastors Association and have had some interactions with them in the past. And our only ask to them was, what, as a Department of Family Medicine, can we do to help you and your parishioners gain better understanding, better health? Please tell us what we can do for you. I think a lot of times in medicine, we can come across as we have the answers, or we have most of the answers. Well, we have some. And it's kind of like when I deal with individual patients, I usually say, I have about 50, we have, a couple minutes. I'll take 50% of the time that I think I need to address issues with, but here, you got 50% or more. You tell me what you think is important and what you would like me to address. I think we have to take that same tact with our community and really find out what's important to the community and what kind of health problems they want us to address.
All right, thank you very much. We appreciate that.
So Grant and Peter, your insights are amazing, and Sharon and Stan, wow, that poem is, it gets to the heart of Medicaid, and unfortunately, it isn't. It's very clear. It's not as easy as just giving you insurance. Mm-hmm. And one of the things that I would ask Peter and Grant to think about, and I think you probably have, is could a community health center that actually did more than just have clinic visits, that actually sponsored healthy behaviors, exercise, etc., could be the place where you could get COVID-19 testing, the place where you could get psychological help and counseling, a one-stop shopping where everything was in one place. Would that sort of address the really 80% that is not the clinic visit? So we'll talk about that. I was asked to just cover why I think COVID-19 has brought out these inequities in healthcare. There are several big reasons. The first is, and both Peter and Grant alluded to this, underlying health conditions. And African Americans, we know, have more hypertension. We know they have more diabetes. We know they have more cardiovascular disease and chronic respiratory problems, and a higher incidence of cancer that's been delayed for therapy. We know that all of these, if you compare to someone that doesn't have underlying disease, they're people die of COVID-19 at 0.9%. If you have cardiovascular disease, your mortality goes up to 10.5%. And if you have diabetes out of control with a bad hemoglobin A1C, 7.3%. Hypertension, 6%. And chronic respiratory disease, 6.3%, and cancer, 5.6%. So having these underlying diseases makes it much, much worse. Now, I've talked in many of our things about many of these town halls about the spread. And it's becoming very clear now that one of the key elements of spread is aerosol, small droplets that you release when you talk, when you're actually breathing. You actually breathe them in. And it turns out in closed environments, they're like an infectious gas that can be inhaled by others. Now, droplets are also important. And then the other big problem, which we've talked about a lot, is 40 to 60% of those that are infected don't know they're infected, and therefore can be spraying this aerosol without even knowing it. So what's very important in the community is to emphasize the wearing a mask. And wearing a mask tells everyone, I care about you, I care about our community. I want to be part to flatten the curve so the schools and businesses can reopen. And I want my county and my state to be green. And I think this is one of the keys. It'll reduce the aerosol. It will remove the droplets. And it's been shown the effect is about 88% reduction in spread if everyone will wear masks. And one of the big problems, and when you don't have as much larger salary and don't have finances, your living facilities are smaller. And we know that with this aerosol builds up in small rooms more so than large rooms, and outdoors is actually the best. And then another important element is airflow. It turns out that the average house, maybe 3 volumes turnover an hour, you need 6 to 8. And another big problem is a lot of the older ventilation is recirculating the room of air within the room rather than bringing air outside. Very important to bring the air from outside. Another important element is staying 6 feet away, social distancing. Well, that isn't always possible if you have a crowded apartment or you're in a crowded environment or your job doesn't allow you to remain socially distant. Mm-hmm. And then avoiding crowds. And greater than 10 people is a worry when you have a large prevalence as we do in our community. And that's not always possible. So when you look at the jobs, what jobs are at highest risk? Well, healthcare delivery is the highest, medical transport, mortuary workers, because they come in contact with the suspected COVID-19 patients. And I had a case of a respiratory therapist, not from Shands, who actually got terrible disease because she didn't have the proper mask to wear, and they weren't given to her. And then there's medium risk, those that may have contact with the general public in schools, high population density work environments, retail, high volume retail. These are all medium risk, and a number of individuals in East Gainesville fall into both the high and medium risk. Then low risk, which tends to be the higher socioeconomic, is minimal occupation contact with the public or co-workers, and they can work virtually at home. The financial areas, a number of different intellectual pursuits where there isn't any need for manual work or physical contact are in that low group. So I think the jobs, so the underlying reasons are high burden of underlying chronic disease, and I think greater access to primary care along with education and along with preventative care, exposure to smaller spaces and poor ventilation, and can we remodel some of these places? I encourage everyone to gather outside whenever possible. And one thought is, shouldn't the schools just construct tents and everybody teach outside? It would be far safer from regards of aerosols. Special facilities for isolation and quarantining. One of the big problems, if someone in the household gets infected, where do they go? They can't afford housing. In a lot of areas now, I know in India, they actually have specific locations that the government pays for to allow you to isolate for 14 days so you don't spread it to your family. Work conditions that result in exposure to large numbers and impede social distancing. work can be reconfigured to reduce these exposures. It's really important to do. And then important understanding everybody in the community needs to understand the risks and be provided with the proper face masks and understand why it is so important and of such value to actually wear them. And then another question, which I don't really have the answer to, is there sufficient testing and contact tracing in East Gainesville? So with that, I want to end and have John Hutton is going to sort of open up. We have a series of questions that came ahead of time.
So just to introduce myself, I'm John. I'm a recent graduate of UF, and I volunteer with the Right Care Alliance. If anyone has, these questions were submitted beforehand, but if anyone has questions that came up during the event, feel free to post them in the question and answer session. And I'm just serving as the voice of the audience, and I'll ask those questions to our panel. Our first question, which is how can we prevent unnecessary COVID-19 exposure from ER visits from common illnesses because families can't afford other options?
I think to avoid, just follow what Dr. Southwick just pointed out. Do the social distancing, make sure you wear a mask, make sure everyone's wearing a mask. People that you're interacting with are wearing a mask. If you have to cough away from individuals, cough into your elbow. Limit your exposure in closed, tight spaces. If possible, exposure from ER visits. If possible, and you have primary care access, call your provider first to see if it's something that can be taken care of in the office or over the phone rather than go to the emergency room.
And our next question is related. It is, how will telehealth help address these inequities?
Well, so theoretically, telehealth helps with one of those kind of physical barriers that I mentioned, kind of the transit issue. And I work out in a rural community out in Dixie County, and we have lots of transportation issues. And so telehealth, when it became sort of on the scene, it originally was sort of thought to be a big fix for rural communities. That was one of the whole ideas behind it. Of course, we have other issues out here, which is lack of good wireless access, which you need for at least the video component of visits. Of course, you can do phone telehealth visits, which we have done actually during COVID. We have a number of patients that haven't had good enough wireless access to do video visits, and so we switched them over to phone visits. And so, it certainly in theory can help in that dimension where you have folks where it's challenging to get reliable transportation to make it to a clinic appointment or something like that. But again, the type of telehealth visit depends somewhat on the technological availability that person has. And also a big issue is, will insurers catch up with how they reimburse for these kinds of visits? And Medicare and Medicaid have done a pretty good job during COVID of, especially when it comes to the video visits of helping create ways for medical practices to be able to be paid for the time that they spend doing telehealth. Maybe a little more challenging just with phone visits alone. But yeah, I think as a rural provider, I certainly view it as a way of helping with some of the physical issues of transportation.
Yeah, Grant, I've been using that for my COVID-19 patients, and a lot of them actually don't manage Zoom well, and I've used the telephone. And I found that actually I had very good conversations with them, and in some ways they were more intimate, and I was able to connect better with them than in office where there's all these distractions and they're meeting nurses and they're waiting in the waiting room. And I was able to manage changes in therapy very nicely by phone. So I think it is an untapped method and I think I was able to bill for it. I did bill for it. I don't know whether they'll pay me anything, but I thought it worked amazingly well.
Agree. I haven't found it to be really difficult to provide care through telehealth either.
Yeah. So I think and we didn't know, we weren't using it much, so we thought it wasn't good, but I think it has real potential. Peter, what do you think?
So, and I think if you look at the studies, and I think our experiences, is telehealth really has improved access. And patients enjoy it, physicians really enjoy it. It does add to some intimacy. We're really not clear yet about the quality of care provided. Is it the same as face-to-face visits? But those studies just haven't been done yet. I guess the only downside, and I think Grant pointed it out, is if we don't resolve some of the disparities or inequities, especially like an IT connection and whatnot, then telehealth is going to be limited. So we really have to concentrate on that infrastructure piece to make sure that all folks have access to it.
Yeah, I agree. Everybody should have internet. That should be like water and electricity at this point.
Mm-hmm.
Our next question isn't quite related to health disparities, but definitely on people's mind. When do you think we will have a vaccine?
I guess that's probably my question. It's, you know, the hope is by January. However, there's some new data coming in just today. There have been 3 patients reported who had COVID-19 and 4 months later got a second episode with a different, by genetic, actual sequencing, a different virus, a different COVID-19, or different SARS-CoV-2 virus. So that raises the possibility of genetic drift. It raises the possibility that the vaccine will not be very protective. And so I am worried, and I think a lot of people are hoping the vaccine will come and everything will go away. I don't think that's going to happen. And I think we really, the things that I outlined, the measures that I mentioned, I think we're really going to have to seriously change our physical environment. We're going to have to really be conscious when we're out in public, because I think that masks are here for a very long time. I would not count on a vaccine, even though there are a number of companies that are pushing ahead and so far have had success. They're in phase 3. Phase 3 is a larger trial, and after phase 3, they will release it. The other issue is cost, and that's where inequities may come up. Some of the companies want to make a profit. Others, AstraZeneca is going to provide it at cost. But what are we going to get where we are, and who's going to get that vaccine first? I would argue that those that are on the front lines that are most highest risk, those with underlying conditions, should receive it first. And along with the thinking nursing home employees would be high on the list as well. So there are a lot of issues. It's very complicated. Bottom line is I wouldn't count it anything until January of 2021, and that is exceedingly optimistic.
You mentioned genetic drift, Dr. Fred.
Yes, yes.
What is that?
Oh, genetic drift. What happens is there are little mutations in the virus. Okay. The virus is an RNA virus, and it reproduces its RNA through a polymerase, and it turns out RNA viruses don't reproduce exactly the genetic code as accurately as a DNA virus. And so what happens is they put in the wrong code. And so little mutations occur, and then that changes the structure. So the immune system is attacking one set of surface proteins. If there's a change in the genetic code, the proteins vary a little bit, and then the vaccine won't see them.
I got you.
So Sharon had a question about this. Sharon, go ahead.
Thank you, Dr. Southwick. Just in general, as I listen to the conversation, I want to make a statement, and it just that needs to sit on its own, which is to say that for everything that we have discussed this evening, if it is bad for the population as a whole, if it is bad for people and people of color and people who are poor and people who are uneducated, it just goes on and on. And so I think to myself sometimes when we were talking, especially Dr. Harrell earlier, mentioning access to food and healthy ways to prepare it. What our society would look like if a physician could write a prescription to a farmer's market or a supermarket and not just to a pharmacy. The Florida Conference is working in partnership with St. Luke's United Methodist Church in an End the Hunger seminar series, which includes work with an organization called the Black Church Food Security Network, which was started by a pastor in Baltimore precisely because he said he became so tired of visiting members of his congregation, a largely African-American congregation, where the healthcare concerns were directly tied to nutrition. And he realized that the closest place to shop for fresh fruits and vegetables in proximity to his church, so he could walk to that place, was a place where the prices were so high that if he had to shop there on a regular basis, he could probably not afford it either. And so I think so often, whether it's COVID or not, there are inherent parts to our system of daily living that just are not designed to meet the needs of people who have underlying health conditions, don't have access, don't have the kinds of jobs that allow them to take off in the middle of the day for a 2 o'clock appointment. I mean, the list goes on. And we have named a number of them tonight, but we just are in a position to begin to create a totally different system in the United States that doesn't work for some and work against others.
Related to what Sharon just said, are there any examples of successful programs where improving social aspects have already shown positive results? Peter or Grant?
Well, I mean, I don't know if I can give you necessarily like a specific study. I was about to say, just to piggyback off what Reverend Austin was saying.
Yeah, go ahead.
You know, well, it kind of relates to that question as well. So there's a program, you know, called Fresh Access Bucks, which is a federal program that essentially doubles a person's food stamp allotment to be used specifically at farmers markets. So you use these Fresh Access Bucks only at farmers markets as an opportunity to, you know, get access to healthy and fresh foods. And that's just one small program, but you could imagine that type of program, which is wonderful for the people who use it and is very successful, and probably half of the medical providers in the county don't even realize it exists because it's not well advertised. But you know, programs like that do work. The problem is they're just not they're just not expanded enough. They're not, you know, stable enough. A lot of times they operate just on the margins because they're not viewed as foundational and integral to achieving good health for, especially for people at lower income levels. So, you know, there are programs like that. There are in cities around Florida, there are examples of, you know, mobile farmers markets that utilize partnerships with corporations to provide, you know, cost-effective fresh foods. They, you know, some of these programs, Ebony Nutrition is one that operates out of Orlando. That's terrific. And they, you know, run classes for the community. They're located right in the, you know, the middle of Orlando in one of the areas of highest poverty. And so they, you know, they have a whole curriculum on health education and nutrition and are doing wonderful things there. So these kind of programs do exist. It's just you're always scrapping and clawing to find grants and to find creative ways to keep these programs going, rather than it being the emphasis of the insurer or the state government or federal government to say, this is what we're going to put big dollars into and make sure that these things succeed. So it just comes from a changing of priorities. And I agree, the way we need to think about health in the future is we need to put emphasis on these type of programs and not emphasis on how can we get more MRI machines or more, you know, biomedical equipment. So I think it's possible, but it takes advocacy at our, you know, at the community level to talk to our leaders and to our, policymakers. The Choices program, that's a program that exists right now in the county that basically funds the healthcare providers for the uninsured and underinsured, and that's been a great program. Well, it's going to disappear in 6 years unless we do something about it, keep it funded. And if we don't keep it funded, a lot of the mental health, dental health, and primary care access for uninsured or underinsured people is going to substantially drop off. Well, if voters are aware of these things and constituents in the community are aware of these things and lobby our political leaders, well, there's money in the budgets to keep these things going, but we have to make sure they're a priority.
And Reverend Austin, to augment what you say, there was a study done in the late 80s, and we all know heart disease, cancer, COPD, and all that are the leading causes of death just across the country. What they did in the study, though, they went and looked at the underlying causes of those problems, right? And so the underlying causes of those problems are poor nutrition, lack of exercise, tobacco use, and then trauma. And so I think what you're pointing to is, yes, why don't we emphasize nutrition, not only in underserved populations, but also across the globe? I mean, that should be a priority, right? For everybody, because nutrition, regular exercise, decreasing tobacco use, and some of the other more social determinants of health are really going to have the biggest impact, especially in the Black community.
Diane D'Imperio wanted to emphasize that that expanding Medicaid is very important, and I agree. And may have gotten the misimpression that we didn't think that Medicaid expansion was important. I can tell you that paying for healthcare is the leading cause of bankruptcy in the United States, and if you get seriously ill and you have no insurance, you will go bankrupt. So, there also are a number of studies, and Peter and Grant can speak to this better than I can, but they've compared states that have expanded Medicaid to those who have not. And there's definitely an increased mortality in those that do not have an expansion of Medicaid. I think it was about 1 in 800 persons dies if the increased death rate if you haven't expanded. But Peter or Grant, could you comment on that?
Yeah, I'll just clarify. So my point and what I was saying is not that expanding insurance coverage, or hopefully maybe we'll be in a world someday where the concept of insurance is obsolete and we just recognize that people just need access to healthcare and it's just a right, has nothing to do with insurance or not. But my point is that we can't stop there. Like once, because that will probably be achieved at some point where we will have universal, insurance coverage or however, but that's a starting place. That's not the ending point. And I feel like a lot of our policy discussions and goals are around just achieving that. Well, once we achieve that, now we've got to really dig in to how do we get people healthy and healthy for the long term, and having access is certainly one important aspect of that, but it's not the end game. And so I think that was my only point. I certainly would be thrilled if the state of Florida expanded Medicaid.
Now, Shirley Bloodworth had a question. Sorry, John, I just saw this and it's pressing. We're running out of time. How can the community and medical community push and assist we get immediate testing, simple home testing? Do you think that the test is efficient, and would it help us manage the illness if we get immediate feedback? So that's a complicated question. And I would tell you that there's a lot of new tests coming out, antigen tests, which can be actually interpreted in 15 minutes, and they theoretically be home. One thing that was just done yesterday is the FDA will not actually will not control the release of these new tests. They're going to let them go out there. The one problem is some of the tests are likely to be highly inaccurate and will delude people into thinking they've got a good test. So it's going to be a bit of a free-for-all before we find out which of these tests are sensitive enough and specific enough to be useful. So I think that is on the horizon, but it's very, very complicated. And I think it's not going to be readily available right away.
So the next question is, how confident can patients be that insurers and payers will cover all costs of their COVID-related diagnosis and or treatment, and that patients will not be stuck with the bills from their providers?
I don't think we can guarantee that. That's why we need Medicaid expansion, and everybody needs to have, there needs to be universal health care. This is a problem. I don't know, Peter and Grant, have you found patients that have gone bankrupt because of these medical bills yet?
I think it's still, I mean, it's a very good question. Difficult to know. We were looking at financial information this afternoon, and the payers are paying for the telemedicine visits. And it appears to be pretty across the board. So at least the initial assessment is good, but more to come, right?
Yeah, and one of the ironies, I don't know, I'm sure you guys know this, that actually insurance companies are making a lot of money right now because a lot of the elective things that were done in the past aren't being done because people are afraid to come to the hospital. So they're actually making huge profits right now.
Okay, our next question is essentially, how do we band together to effectively cause legislative change?
Do you mind if I talk to some of this? Because I'm pretty passionate about this. I think there's a couple things. We have to stop being complacent and re-electing people that aren't doing the things we ask them to do. You know, I see people that are in Congress, they're in their third, fourth, fifth, sixth term, and we look at it and we look at them doing absolutely nothing. We need fresh blood to come into, whether it's the Florida legislature or the national legislature. We need new people, new ideas. We need a lot more variety in a cross-section of our population. It can't be all, forgive me, but old white men. It needs to be a good cross-section of our entire population. And we need to stop electing these people. And it doesn't matter if they're part of your party. If they're not doing what they're supposed to do, then we need to find other people.
Yes.
I think what we see is we see them come on television and they speak and they tell us what they want to do, rather than saying, this is how I'm going to represent my community because I've talked with my community and this is what they need. And we need to demand more out of those legislators. And in the meantime, there are so many different things you can do, whether it's writing to congressmen, attending protests. There's just a lot of things that we can do. And we have to do a lot more of it. I think that the last 4 years, if they've shown us nothing else, no matter whether you're Republican, Democrat, Independent, is that we're very fractured. Our legislators are not even willing to talk to each other to affect change, and we have to fix that. It doesn't matter which party you're with, we need to get people in there that will work together and make our country a better place and give us things like universal health care and help bridge the gaps and the inequities that are across all of our communities.
To that point, the Right Care Alliance for the next, is it 70 days or 69 days? We're going to be dedicated to, we're going to work with the Alachua County Election Commission to facilitate registration and make sure that those are registered, have all the accurate information, and to help get out the vote. So that's going to be a very important effort, because I don't think, as we've alluded to, if we don't get Medicaid expansion, we don't have insurance, if we don't have a new system that takes into account all these social determinants of health, which are a lot of them are out of the control of the physician, but need to be improved for physicians to do what they do best, improve health. And we feel, I honestly feel quite powerless at this point, because the number of challenges are so many, and the hill to climb is so steep at the moment, that we need a change in our overall system for us to impact all the 80% of what's going on in health.
Just quickly, can I say, please also don't forget to work in the city of Gainesville and in Alachua County at a local level with our local leaders to figure out how to use the funds that we raise locally in the wisest, most effective way. A lot can be done with a lot less than you realize if we're just smart about what we do and how we even use our local resources. We understand our community a lot better than our state and federal legislators. And we can really figure out how to use our money as wisely as possible. And so think about ways to act even small at the local level. It can make a huge difference.
Some of, Father Allen visits, about 80 patients a day at Chan's UF Health?
Well, before my injury, that was true.
Okay. So he has a huge experience on what patients are thinking about their health care and what their challenges are. And I wanted him to share a few examples.
Okay. And before I do that, I just want to let you know why I was delayed joining you. I got a page shortly before you were to begin, dying patient at Shan, so I had to go, and that really messed up everything. Anyway, over the years, a fair portion of our people, particularly the homeless, that's perhaps the most common lack or no insurance at all. They just, sadly, they're disenfranchised from their families and they're just floundering. And it's very sad because I don't know what can be done to really help fix them per se. But like you said earlier, I've seen, not only the uninsured have great difficulty getting the kind of health care they need, but with insurance, depending on the malady, like you said, the greatest reason for bankruptcies in our country is the cost of health care. And certainly that needs to be addressed. But I think, I find a fair amount of people, particularly the ones that are younger, get caught off guard. They kind of think it won't happen to me. And we need to impress all people that, one, we will help each other if we all participate in healthcare. And, just going along and thinking it won't happen to me. And then when it does, you're totally ill prepared. So I find that to be a common denominator, either of the unavailability of insurance through their work, or they just didn't take it seriously and thought, I don't have to worry about that until I get 40 or 50 or something like that. The patient I went to see today, she's about 25 years old and dying. Yeah.
Actually, President Fox gave his address for the university today, and I was really impressed. The end of his talk was, he said something I think relates to our entire community. He said, we're under a time of great stress. What's most important is to be kind to each other. And I can think of no better way to be kind to each other than to make sure that we're all taken care of, that we all have health care, that we're all healthy. And we are only as good as our weakest link. And that has been one of the problems with this epidemic, is that many that don't have access are the ones that are getting sickest and then spreading the infection. So it hurts us all. And it's really been very, very sad to see this disproportionate number of African Americans and Hispanics actually suffer with this infection. And for the reasons I explained, it's pretty clear why that's happening. And it's a call, I think it's a call to all of us to be concerned. And I think Peter and Grant they've been working on this all along. And I think we all need to, as a society, work together to break down these inequities and look at them, as Sharon, I think, is very clearly outlined. And our poet laureate clearly described in his poem. Stan, that was an amazing poem. So I want to thank everybody. This has been an incredibly rich discussion.
Dr.
Yes.
Fred, another contributing factor with all the people I've seen the last almost 12 years, I've become increasingly more convinced one of the contributing factors to the overall problem is the sad state of our public school system, because the kids aren't getting the education they need to really get the kind of jobs that will help them take care of a lot of these things. And it's sad when I see so many ill-informed, undereducated people And I'm wondering what in the world were they learning at school? And basically, they're not learning much. They're learning how to punch buttons, but not how to think. And it just reduces them to the meager leftovers.
Father Allen, poetry can help immensely with critical thinking. Creative writing helps with that.
Yes.
But
Yes.
what I wanted to ask, if we could have another one of these type of town halls where we could invite Diane Dempiro, who she's actually the person that contacted me from the Florida League of Women Voters, who asked me if I would assist them with their Medicaid expansion media thing with the state of Florida. So we could have another one of these, and where we just talk about efforts or try to mobilize people to put pressure on the legislators to expand Medicaid. So I think that'd be something worth looking into.
Yeah, definitely. We'll consider that. We're also going to have meetings that are not so structured. We're going to have, I think it's September 2nd, we're going to have a coffee hour from 5 to 6 where people can just share ideas, anything, right open. And we can talk about some of those things.
One more thing, is there a patient, is there an advocacy type group? There are a lot of times when people go to the hospital and they're reluctant, they're afraid, they're intimidated by, I call it the white coat syndrome. People are reluctant to talk to doctors or I mean, and I learned this from my mom, watching her interact with my father and interact with her children. And I did the same thing with her before she passed. When she got elderly, she would go to the hospital doctor. I would spend at least 30 minutes with the doctors and the nurse, the whole staff, letting them know who she is, you know, and advocate for her best care possible. I just want to know if there was like any kind of group like that where it could help patients.
Yeah, there are advocates. There are advocates.
Okay, cool.
And patient representatives that actually work very well. I know a number of them, and they're very pro-patient, and they really look through their eyes. So
one of the things about talking about racial disparities is about, you know, I mean, a lot of in Black communities don't trust.
I know trust is very important.
Don't trust the kind of what kind of care they're going to get when they actually go to the hospital. It's just another thing. What if you get stopped by the police? That's anxiety. Doctors the same way. You know, are they going to help me, or are they going to help me get to the afterlife quicker?
And one of the things just in medical education that we are really trying to emphasize more and more and taking much more seriously is educating our students on how to be advocates for their patients themselves and communicate at a level that is understood by patients in a way that is culturally sensitive, that is aware of biases. We are doing our best to try and really revitalize our curriculum to address that, because it's a major problem.
An excellent idea to do that. I've encountered doctors that that had no idea how to talk to regular people. I mean, it was very condescending, and they were excellent physicians, but bedside manner was
a major problem.
Yes.
I really want to thank everybody. This was not only an informative and enlightening, it was spiritual. This was a fantastic event. I want to thank all of our presenters, Stanley Richardson, Father Alan Bauer, Reverend Sharon Austin, Dr. Grant Harrell, Dr. Peter Carrick, of course, Dr. Southwick, and I'm going to do a shameless plug now for the Right Care Alliance. We really implore you. Somebody asked, how can we, work with legislators? Well, groups like this want to do exactly that. The Right Care Alliance, we welcome anybody. We welcome your ideas. If you're interested in joining, you can go to rightcarealliance.org, sign up through there. And again, thank you everybody that presented and everybody that attended. We really appreciate it.